الدكتورة جيهان جمال هتقدم لنا البرزنتيشن الجاي ان شاء الله.
Good afternoon, doctors. My name is Gehan Gamal. I am a radiology resident at Ain Shams University, and I am here to discuss some interesting chest cases that I came across during my chest rotation. In our first case, we have a 46-year-old male patient who came to the ER after a road traffic accident. The patient presented with hemoptysis. He was severely dyspneic, and there was decreased air entry over the left lung. The patient was then intubated, and urgent CT brain and chest were ordered. The CT brain was free, but let's have a look at his chest scan. As we can see, the lower lobe of the left lung appears collapsed, together with a mediastinal shift towards the left side. What else? The left main bronchus is seen attenuated compared to the other side, with surrounding foci of air around the left main bronchus, as shown by the red arrow. The blue arrow points at fluid density present inside the left main bronchus and extending to the lower lobe bronchus. Based on this description, can anyone guess the diagnosis? This is a case of a left main bronchus injury, where causing air leak, forming the air foci. The fluid density probably represented hemorrhage. This injury caused collapse of the lung and a mediastinal shift. Now, most traumatic tracheobronchial injuries, they commonly occur with multiple rib fractures and other associated injuries. So we had to look for rib fractures. Surprisingly, there were no rib fractures. The liver and spleen were unaffected as well. And this makes the case an interesting one of an isolated tracheobronchial injury, which is a rare event. Another case of a 68-year-old female patient whose previous CT chest showed evidence of pneumonic changes, and another CT was done 1 week later for follow-up. We compared the new study to the previous one and found a newly developed right-sided mild pneumothorax causing partial collapse of the right upper lung lobe, together with tracheal contour loss in the form of an irregularity seen in the right posterolateral wall of the trachea and related pocket of air as shown here. What's the cause behind this? We noticed a newly inserted endotracheal tube, and that directed us towards an iatrogenic tracheal injury. In both these cases, fiber optic bronchoscopy was done, which confirmed the diagnosis. Tracheobronchial injuries, they result from a variety of causes. We've already mentioned traumatic and iatrogenic injuries. Other causes include penetrating, inhalation, tumors, and aggressive infections like TB. The diagnosis is usually made with chest X-rays, CT scan, which is the main modality, and bronchoscopy. Chest X-ray, they may demonstrate secondary findings like pneumothorax, subcutaneous emphysema, and pneumomediastinum shown here as air surrounding the left cardiac border. CT can detect tracheal and bronchial wall defects. The fallen lung sign is a rare but a specific sign for complete bronchial tear, where the collapsed lung appears away from the hilum at the dependent area of the chest. The key takeaways are that tracheobronchial injuries, they are rare but life-threatening. Rapid diagnosis and establishing a clear airway can be life-saving. The management includes a multidisciplinary team and management of life-threatening collateral injuries. Surgical repair is often needed, but non-surgical options may be an option in some cases. Our last and final case is a female who is 23 years old, complains of dyspnea on exertion of 1 year duration. High-resolution CT scan was done, which showed bilateral peripheral subpleural areas of reticular infiltration and pulmonary fibrosis seen mainly affecting the apical and anterior segments of both upper lobes as well as the superior segments of both lower lobes. These interstitial manifestations were seen distributed in all 4 corners of the thorax. This is referred to as the 4-corner sign. There is also some honeycombing changes noted there. Now, this is a case of interstitial lung disease, but this form is different from the idiopathic form, which mainly affects posterior segments of both lower lobes and occurs in ages over 40. But in this case, these manifestations involved the upper lobes as well and occurred at a younger age, so we must suspect either chronic hypersensitivity pneumonitis versus connective tissue-related interstitial lung disease. But we found something else. There was esophageal dilatation with fluid level, as shown here in this picture, which made the diagnosis of connective tissue-related interstitial lung disease more likely, specifically systemic sclerosis. To sum up, if you find a case of interstitial lung disease with 4-corner sign, esophageal dilatation, and affecting a younger age group, you must suspect underlying connective tissue disease. Subsequently, the patient did the relevant investigations, and the autoimmune markers for systemic sclerosis turned to be positive. This is the end of my presentation. Thank you very much.